Okay, guys, so welcome to season 2 of the Manifesto Read.
Whoop, whoop.
I'm OJ.
And I'm Io.
And as you guys know, I'm a barrister and he is a management consultant who studied politics
degree.
at university.
Yeah. Thank you.
Okay, all right, we got it. Okay, all right, thanks, Io. All right, so season 2 was intended originally to be a 100-day review of the Conservative government. However, circumstances have changed.
Yeah. And due to the outbreak of the coronavirus, we figured that it would be best to use season 2 to really kind of talk you through what's been happening with the coronavirus and how that impacts all the different policy areas and additional policy areas that we covered in season 1.
Yes, so the breadth of the practices of our panellists will hopefully mean that we will be able to share some refreshing insight into how coronavirus has and will continue to affect all of us. And we'll also try to share practical tips, advice, how to navigate this difficult time. And as ever, if you guys have any questions you'd like to answer, then over the course of our episodes, get in touch with us via Twitter at Manifesto Read, via Instagram, which is at The Manifesto Read, or email us at themanifestoread@gmail.com, and we'll do our best to cover everything that you ask us over the course of this series.
Yes.
Now, due to social distancing, how are we recording, IR?
Well, we are all recording via Zoom, which means that although we aren't able to do our funky sound recordings in a sound studio with lots of mics and all that kind of stuff, we're doing some Zoom recordings. But what that does mean is that we're going to be able to provide you with video recording, which will go onto YouTube after this episode has finished. Whoop whoop.
Yeah. Yay.
I'm less excited about that.
So bear with us because the quality of the sounds we know is not going to be as good as it was in season 1, but hopefully the quality of the conversation will be just as strong. So we are kicking off with our health and social care episode.
It's a little bit better to start, to be honest, yeah.
Yeah, and so why don't we allow our wonderful panellists to introduce themselves, starting with Bami Afolabi.
Hi, my name is Bami Afolabi. I have been running care homes in East London, Essex for the last 9 years. I've taken a short sabbatical from that to pursue a degree in global health at Barts in London.
And next we have Danielle.
Hi, I'm Danielle Solomon. I am a public health doctor and I'm currently a Wellcome Trust clinical PhD fellow. Oh, can you hear me?
It sort of froze and went off. So do you want to do that again, Danny?
I feel like no.
Oh, I think the signal has.
Yeah, I will give that another try. Can you hear me now?
Sort of. It's a little bit fragmented.
Okay. Do you want to move to someone else, and I will try moving to a different room. Hang on.
Okay.
All right.
We'll go back to Danielle, and we'll go over to Daniel.
Hi, I'm Daniel Mallin. I am the South London Vascular Networks Manager, and I'm a former Senior Policy Advisor at the Department of Health. And I also sit on the Advisory Committee for Progress Educational Trust, which is a assisted conception and genetics charity.
Great. And next we have Felicia.
You're on mute, Felicia.
Hi, I'm Felicia Lawajana. I'm a GP in North London, and I'm also work with North Central London sort of boroughs, working on GP retention and recruitment.
Brilliant. And penultimately, we have Ros.
Hello, I'm Ros Hawley. I'm a management consultant at a firm called 2020 Delivery, which specialises in public sector projects. And so I've worked across the health system from frontline staff in NHS hospitals right through to the NHS England and national bodies.
Great. I think we have momentarily lost Danielle. So what I'll do is I'll be a bit cheeky and I'll do her intro for her. So those of you that listen to Series 1 will be familiar with Danielle's background. She's quite formidable. She's a specialist registrar in public health and a Wellcome Trust clinical PhD fellow at the Institute for Global Health at UCL. She graduated in medicine from Oxford. She's got a master's in public health from Harvard, the Chan School of Public Health. And prior to specialising in that area, she practiced as a sexual health and HIV physician at the Mortimer Market Centre in central London. And I think that she has just come back. So Danny, I've stolen your thunder slightly and done your intro for you.
Okay, that's fine.
Okay, but let's kick into the actual episode itself. I think what would be really good is if we start off with just an overview of what exactly we're dealing with when we refer to coronavirus and when we refer to COVID. So Felucia, can you give us an idea of what COVID-19 actually is, please?
So the term coronavirus or coronaviruses is actually an umbrella term. So coronaviruses represent or the name for a family of viruses that tend to cause illness and disease affecting your respiratory tract, so from sinuses, throat, lungs. Coronaviruses include the common cold that's caused as a coronavirus. So you can have a mild common cold, and then you've got COVID-19, which we're dealing with now. Another more severe, well-known coronavirus is SARS. So SARS is severe acute respiratory
syndrome.
And that's another coronavirus that we kind of heard about maybe about 15 years ago. That was big. And now we have COVID-19, which is named COVID-19 because it's a coronavirus that was discovered in 2019. And that's basically a summary. So
elementary.
It's a virus that affects your respiratory tract. It affects the body, or is transmitted in the same way as most other coronaviruses, like the common cold. But this one has much more severe outcomes and seems to be spreading at a more alarming rate.
Okay, and so in terms of the current health advice, obviously we're in an environment where it is rapidly changing, and each day we're getting more advice, we're hearing different nuances in terms of what we're supposed to be doing, what we're not supposed to be doing. Danielle, could you give us an overview of what the current health advice is as of today, and just so that our listeners who may be listening to us at a later date know, today means the 24th of March 2020.
Yes, happy to. And as you said, you've already done my introduction, but just to clarify, I'm in public health, so the guidelines are my bread and butter. But I know that they've been changing quite a lot.
I need your number, basically.
Oh yeah, exactly. So I think the good way to split them up is what you're meant to do to stop yourself from getting COVID, and what you're meant to do to stop other people from getting COVID. So the best way to protect yourself is to wash your hands more than you otherwise would, as much as possible, really, and to wash them with soap for 20 seconds. I'm sure a lot of you have heard that you should be singing Happy Birthday twice while you wash your hands. There are a lot of Twitter threads about other songs that last for 20 seconds. Go nuts with them. The other things are coughing or sneezing into either your elbow or into a tissue, and making sure you throw the tissue away. And staying 2 meters away from anyone else. I'll talk a little bit about isolation and self-distancing in a second, but those are the main things in terms of trying to stop other people from getting coronavirus. The big thing that people recommend is act as though you already have it. Don't act as though you're trying to stop yourself from getting it. So stay away from people and keep your hands clean. Also try very hard not to touch your face, particularly if you're outside. The other guidance is to do with stopping other people from getting coronavirus if you already have it and you know that you have it. So any symptoms that are cold or flu-like symptoms, particularly a new persistent cough or a new fever, you should stay at home for 7 days. And that's on top of the current lockdown that we currently have. I know, are we calling it a lockdown? I'm not sure, but I know that we're, at the moment, we're pretty restricted with what we can do in terms of going out. But if you're symptomatic, please don't leave the house at all for 7 days. And this is where it gets a bit confusing. If someone who you live with is symptomatic, so if they have a cough, if they have a fever, if they have cold or flu-like symptoms, you need to stay in with them for 14 days. And the reason for that is because there's a period of time called an incubation period where you may be infectious, but you might not yourself be showing symptoms. So what we ask is that during that time when you might yourself not be sick, but you know you've been in contact with someone who is, you stay at home, and then another 7 days, just to make sure that by the time you go out again, you're not going to pass on the virus. To talk a little bit about self-isolation.
Could I ask a question on that in terms of that period,
of course,
the 14-day period and the 7-day period? When we first got advice about how long you were supposed to self-isolate for if you demonstrated any symptoms, so the new cough or the fever, we were initially told as individuals that we were supposed to isolate for 14 days, and then that was reduced to 7 days for individuals and then 14 for groups. Are you able to explain why there was that apparent change in the advice that we were given by the government?
Yes, I think we've had a better understanding now of how long someone's symptomatic for, is infectious for when they have symptoms. And so about 7 days after someone actually starts exhibiting symptoms, they're much less likely to pass on the virus, which is why we're saying 7 days for people who've started showing symptoms and then 14 days for people who live with them.
Danielle, just to butt in there. Daniel has a question, I believe.
Yeah, I was just wondering if you could explain the advice to people with other health conditions. So there's different advice if you have other health conditions, and I didn't want to miss that off because that's confused a lot of people.
Of course. So yes, this is also where it gets a bit confusing. So in terms of other health conditions, again, we are all meant to be staying inside, and I'll go over that in a second. But in particular, if you are either over the age of 70 or you're someone who would normally get a flu jab from your GP,
okay,
so that's usually people with various respiratory. Oh, hello. Are you guys able to hear me?
No, I think Abby's frozen. We can hear you, so you carry on, Daniel.
Oh, okay. That's fine. Perfect. So yes, if you would normally get a flu jab from your GP, so if you're pregnant, if you're over the age of 70, or if you are someone with various respiratory illnesses like COPD or asthma, you need to stay in as much as possible. But I know that other people are allowed to go out for bits of exercise and go to the shops, etc. But if you're in one of those vulnerable groups, you should basically be staying in the house almost all the time, which is incredibly difficult, but that is the guidance. For everyone else, you should only leave the house to get medical care, to go care for someone, to go to the shops as infrequently as possible, or for once a day for one form of exercise, so one run, one cycle, one walk, and that's about it. Ultimately, the idea of this is that we should not be coming in contact with each other. People should not be coming in contact with each other because a lot of people could have this virus and not know that they have it, and it's very, very easy to pass it on.
Now, Danielle, just a question in terms of that category of caring for somebody else. We've had a question from one of our viewers who's asked to remain anonymous, and they have said if they have a situation in which, for example, they and their partner are both working from home in quite intensive jobs, and usually the person who would care for their toddler is the mother of one of the couple, would that count as that mother travelling to care? So she would be travelling from her home to the couple's address in order to look after that toddler within the confines of their home. Would that be something which is allowed under the current guidance or current rules?
That is discouraged under the current rules for two reasons. So depending on the age of the grandparent, they are quite likely to get COVID from the child rather than the other way around. So they potentially could be in a vulnerable group themselves. So on the whole, the guidance is trying very much to discourage people from using grandparents as childcare, just for one thing. And then for the other thing, on the whole, we're not really meant to be visiting family, which again is really hard. But you're basically only meant to be seeing people that you yourself live with. So on the whole, under the guidance, we would discourage that.
Okay, so that was a really clear outline that we've had there from Danielle in terms of the current situation. We know that there was an announcement today from Matt Hancock, and he has put forward new aspects or new developments which have come across from the UK government's strategy. So Ros, a question for you. Could you explain to our listeners what is the logic behind the current UK policy and how does it compare internationally?
Yeah, so maybe we start with the first bit. So kind of what is the UK policy? And actually Danielle explained a lot of it, but it's you only go outside if you have to. So those parameters are to get essential food, a health reason, so either a pharmacy or a doctor or hospital. But the other one, which has become clearer today, although ironically makes it less clear, is work. And I think we should talk a little bit about that, because I saw Daniel pull some faces earlier when we were talking about, is it lockdown, is it not lockdown? So in terms of the UK strategy, I think we should talk a little bit about that. And then the other policy, as Danielle made clear, was about staying away from people, so 2 meters, and washing your hands and general hygiene. So the work one, I think, is difficult, and actually is picked up by the question you just someone asked you, which is around what do I do to maintain my life, my working practices, but I still need childcare, and that involves an elderly relative or just generally a relative or someone having to move and on transport. And I think this is where it gets a bit difficult for the policy. Matt Hancock said today that they were clear that if you cannot work from home, then you can travel to work and you can go to work. So that is a little bit, I think that's challenging for a number of people, and isn't actually very easy, particularly for people with childcare issues or where they're now expected to homeschool their children. How this compares internationally, so I think I'll just go on to this, and then obviously I think other people want to comment, but I think there's been, the UK government's come under quite a lot of heat about how it's responded to things at certain times on the journey. However, full lockdown, where things like everything has shut, actually has been only used in a very few cases. So, for instance, in Italy, which we know have a number of cases and is struggling to get control of the virus, has only seen very localized lockdowns where literally they just isolate a town. And they say nothing can happen there, no work whatsoever. Again, in China, they had similar policies, but it wasn't a blanket lockdown. It was kind of regional. Maybe that's where the UK government will go. Maybe that's the next step, because we have seen a progression of interventions. So perhaps that might be another level of intervention.
I think Volusia had something that she wanted to contribute.
I actually want to ask a question about that. I mean, it's a very difficult question, but obviously looking at Italy and what's happened there, is there not an argument that we should go further sooner to try and prevent them trying to play catch up with controlling this virus, and perhaps go into isolating for certain areas, complete lockdown? Particularly London is sort of the centre of the pandemic in the UK. Should we not just lock down now? And it's sort of short-term pain, long-term gain. We can't leave our houses for a month, but we don't get to Italy's point. That's just my suggestion.
So I think I wrote a bit of a sarcastic comment in the script when you ask us questions, and I said that ironically we now all love an expert, which is the irony of Michael Gove saying we're over experts. But I think we've got a chief medical officer in Professor Chris Whitty, whose entire life has been devoted to the studying of how diseases are spread, and it's kind of like the perfect person to help advise a government through a pandemic. And I think trying to say, oh, that's what Italy's done and they're still really bad, this is what China did and this is how it comes, is very difficult. And to say, oh, the UK should follow only what other countries are doing and do just as draconian measures doesn't quite work. So Italy could equally be argued that it was worse than it will be in the UK because they don't have a completely national health service. There was a mixture of public and private having to work together for the first time ever, and it didn't really go well from what colleagues that are in Italy do. And the same with China is we can't go to full on China because we have human rights and we can't do lots of things the Chinese government can do. And also we have a very different economic model. So I find this constant, oh, the UK should be doing more. I think it has to be evidence-based. And let's be honest, we had the first death from coronavirus 18 days ago. If someone tried to make us go into lockdown even 10 days ago, I think we would have said, no thanks, mate, and would walk around. And there's 60 million of us. There's not enough police and army for the love of us to get us all back into a house.
And I think Rose was just raising her hand, so I think she had something to add to that.
So it's in support of what Daniel's saying about the stages, and I think that's absolutely right about if we had had lockdown earlier and perhaps not taken people on the journey, it would have been more of a shock to the system. And just like anecdotally, I feel like, say, I'm in London and I was very for the message that came. Well, it was only yesterday, wasn't it, from the Prime Minister saying these are now quite stringent rules. Whereas I had relatives outside of London who were really like, whoa, like, is this for it? And I was like, I think it's just about stages, and it's about bringing people to a place that they can accept what's going to happen and not fight this, because basically this is going to ideally work on cooperation. It's a lot. It would be a terrible state to get into if the army has to be drafted in and very aggressive and punitive measures. So ideally, you want this to happen by cooperation and kind of a collective action solution rather than problem.
Also, frankly, as we've seen from the way that people have reacted, I think particularly amongst our age group, I think most of the people on this panel would be within the sort of early 30s, late 20s catchment. And I've been quite surprised at how many people have continued to go out, even with the guidance that we've had so far. So it's quite clear that from a sort of behavioural aspect of things, we do need that aspect of easing into things. I think if they had introduced quite draconian measures from the outset, there would have been quite a lot of rebellion and we'd have even less compliance than we've seen so far. Bami raised his hand at one stage, and so has Felucia. So maybe if we go to Bami, because we've not heard from him yet. Just remember to unmute your mic, Bami.
Would be a thing to do. We were told at one point that we would get a degree of transparency with regard to the data used to come to the decisions that have been made. Is there any word on what that might look like when that might materialize? Has anyone heard of?
No, but my favourite ever saying when I was in government was save that for the public inquiry, which was when you thought you were dealing with something controversial and you're like, oh, this is whatever we do, we're going to get told off. There was no right answer. It was this, save that for the public inquiry. And it's like that email you sent to say, this is happening, this will go badly, I'm just letting you know, make your decisions. So I assume we'll have a thorough review in some form of inquiry post facto in the lessons learned. Ross wants to join in on that one.
No, I think it's a good point. But I think, and this goes back to Felucia, your point, and also kind of, I mean, what you were saying. The problem with the draconian and measures and whatever the data source is, but going straight in is then what do you do? Because there's no clear exit strategy to this. I think we're going to discuss this later in the session, but because you're not going to have lots and lots of people potentially catching, because we're trying to flatten the curve. We don't want it all to peak at one point because we don't have enough capacity. You need to be able to save the measures or keep enough bandwidth in the system such that potentially we may oscillate for quite a while between going from quite draconian measures and lockdowns to having it a bit more freeform, and draconian measures in a bit more freeform. And the data, I guess what's happening is perhaps they don't want to release the data just yet because I think there's a lot more of the story to come, if that makes sense.
And Roz, can you just explain, because I think that the phrase flatten the curve is something that we've heard quite a lot over the last few days. Can you just explain in layman's terms what flatten the curve actually means?
I will do my best, but essentially, if you have a graph of basically time and deaths, what you're trying to do, or outbreak, but really we're talking about deaths, is if coronavirus has quite an aggressive line, so like it's doing this and it's going straight up, what you want to do is to try and pull it down so that over time you'll have more cases over a longer time period, but you're bringing down that death rate, and basically you're bringing down how much the system, i.e. the NHS or healthcare systems around the world, have to cope with at any one point, because we know that things like intensive care beds are of a premium, and the staff that can actually, and the equipment that you need to save people's lives. So that's what we're talking about. It's not a solution to the a solution to the problem, because ultimately the virus will still be around. You're just extending the time. You're trying to bring it down.
So it's about management really. So it's about managing it and making sure that it's within the sort of capacity and the sort of resource level that we have and are able to actually deal with.
Yeah.
And to put this into stark context, I believe, correct me if I'm wrong, experts on here, that we have 5,000 ventilators with the further 7,000 being supplemented today. Is that correct? Just to kind of give an idea of how little or how scarce the resources needed to combat serious illness attributed to coronavirus is. We have 12,000 ventilators for the whole of the United Kingdom. Is that correct? Does anyone know?
I don't know the number of ventilators, but I was reading.
It is about 5,000 in the UK at the moment. Maybe a negative comment is we do have one of the lower ICU beds per population compared to other European countries, so we're already kind of starting off in a worse position because there are less beds per 1,000 of population compared to some other European countries. I'm not sure the details of the supplementation because that's all happened today with this new announcement, so I've been at work, so I don't know exactly the numbers.
So Danielle's got her hand up, so I think she might have the response that we need.
I don't have the response that we need. I don't know the exact numbers. I just want to say, because it's been one of those things in terms of looking at the health service as a whole, that there's been a lot of discussion about how many ventilators we have, as if ventilators are autonomous machines that just work on their own. And a managed ventilated bed requires so many staff, expert staff, often people watching that patient 24 hours, because that is a very, very sick patient and someone who's using very complex equipment. So it's not just about having, because there's a lot of talk about converting factories to make ventilators. The ventilators require some very specialist doctors and nurses to operate them, and you can't just train those people out of nowhere. So that's part of the capacity. I just wanted to point that out.
So that leads into, I'm sorry to interrupt guys, just to circle it back in terms of
we'll be going over again
of today's announcement. So Mr. Hancock has said that they have recently brought out of retirement quite a large number of recently retired NHS staff that have responded to the call to return to service. That's included 2,600 doctors, 2,660 doctors, over 2,500 pharmacists, and over 6,000 nurses as well. So in terms of what Danielle was just saying, are those one of the reasons that we've had that call, in terms of just like bringing back that specialist knowledge and making sure that we have that level of resource available to us within the NHS? So Felucia had a hand up, Danielle and Dan, I'll let you guys battle to sort out who responds.
Felucia was first.
Thank you. Well, that is why the call was put out, because clearly workforce is going to be a huge issue. I think the irony, because I've been working in GP recruitment and retention for the last 18 months, which is kind of part of NHS England's plan and the long-term plan and Boris's plan, which was mentioned lots over the past 6 months about getting 5,000 new GPs from somewhere, supplement the primary care. I'm primary care focused, by the way. I'm not very much secondary care focused. Getting 5,000 more GPs to supplement this dwindling primary care workforce and creating how many million new appointments. And it's just funny that we now have to do all of this that was supposed to be a 5-year plan in like 5 weeks, and now we're literally doing the right thing, but getting GPs out of retirement and doctors out of retirement is the only way we're going to be able, one of the only ways we're going to be able to supplement the workforce. Because as Danielle said, you can't train these people up from nowhere. Although they're doing a lot of other workforce management, so medical students might have to start their rotations early. So usually medical students finish university and go back in August, but they're probably going to have to go straight into work. They're taking people out of training posts to go and kind of help in hospitals. So they are doing a lot to trying to get the expertise from different places. But as Danielle said, you can't kind of create expertise from nowhere. These people need to be trained, and some hospitals are actually at the point of training other specialties. So to be able to help with sort of ITU patients, that they're training doctors who would never usually be involved in ITU or ventilation, giving them sort of very robust, thorough training, but training they would never have ever had if it wasn't for this virus.
Episodic story on this as well.
I don't want to name names.
Don't want to name names, but an orthopedic surgeon who's been trained last minute to ventilate, which I find quite interesting.
This is the point I was going to make, and it touches on what Danielle says, is you can make new ventilators and you can try and quickly throw loads more ventilators into an area, and you can get loads of retired GPs, but actually what you need is people that have managed critical care beds, who have been in intensive care. And with the greatest will in the world, those 2,660 doctors were not all critical care consultants and intensivists that have retired. There can be a real mix. And so what we really need is to upskill the staff we have. I work with very highly skilled surgeons every day. They're great at the thing they have spent the last 20 years learning. They are not going to be very good at going back 3 or 4 grades and becoming registrars that have to manage wards because there's no one else. Love them all to bits, and they will say the same. Some I have absolute faith in. But what is happening is our specialist nurses that may have been in vascular or cardiovascular but had worked in intensive care or other critical care bits are just saying, well, you did that 2 years ago, you could be really quickly upskilled back to the level you were at to learn the skills that have happened in the 2 years, and you go back. So what some of these people that are coming back in the workforce, they won't be going into the intensive care unit, but what they might be doing is letting workforce who is better place to be redeployed back into intensive care, their job being backfilled, because coronavirus is terrible and it is a health emergency, but that doesn't stop the fact that people are still going to have diabetic foot sepsis, they're still going to have critical limb ischemia, that's just ones I deal with, they're still going to have cancers, they're still going to have all these things that need to be looked after, and they're not looked after because everyone is on coronavirus. All we're doing is building up another health emergency in 6 months' time. So the people coming back may not be the intensive carers we need, but they hopefully should free up current staff to be redeployed to a much better place to learn all the new skills they have to.
I see Felicia had her hand up.
My front door's going? Sorry. I'm not expecting anyone. I live alone.
Don't open the door.
I live alone.
Don't open the door, Dan. Don't open the door.
Sorry, just in case you hear a random bell. Probably someone's Deliveroo.
Felicia, yeah?
I was going to add, yes, that's a really, really good point. And I think definitely, obviously, Dan is much more secondary care focused. And a lot of the talk is about ICU and ventilators and all this specialist care. But the overspill is going to be huge onto primary care. So the BMA, I think this week we've got new information that basically does state that people are still going to be unwell and die from other things as we redirect all our resources to coronavirus. And we need to be aware how we can minimize that negative impact on the health of the rest of the population as much as we can. And there's been some guidance about what is safe to defer in primary care, what is safe to say, oh, let's leave that another 3 to 6 months, delay your smear test for 6 months because it's not safe for you to be walking around the streets into your general practice in case you pick up coronavirus. But on the other hand, people delaying those appointments might lead to some negative effects in the long term because something didn't get picked up as early, or they let their diabetes go out of control for a bit longer, or mental health is definitely going to be one that suffers a lot, because a lot of that does require face-to-face appointments. It's already very stretched. They're already cancelling their face-to-face appointments. People are dealing with a pandemic anyway. So the catch up on just health, on people's health alone, outside of coronavirus, is going to be huge, and that's where this extra workforce can also come into play to kind of supplement managing everything else, whilst we've got specialists and other more expertise people dealing with the coronavirus crisis itself.
Well, that leads us on to just a short point. So we had it down as a bigger discussion point, but I know that we can cover it in the justice episode. I know that, Dan, you wanted to discuss this. Maybe we'll bring you on to that episode to discuss it. But obviously we've seen the coronavirus bill is making its way through Parliament. It's gone through the House of Commons today, and there are, as you've all pointed out, some quite pragmatic, some may also say as far as draconian measures which are being brought in, or powers at least which are being given to the government should they need to use them should things get worse. But one of the things that struck me was the relaxation of rules regarding sectioning people with mental health issues, because of course that's an area that requires quite intensive and forensic reporting and checking by mental health specialists. So that could be an indication of this view that there are areas that you can be more relaxed in and be less time intensive about, so that those particular doctors and resources, nurses and so on, can be used elsewhere without causing a backlog for people who are potentially very, very vulnerable even outside of COVID. So sorry, Dan, because I know that I've taken that away from you in terms of the topic you wanted to discuss, but I'm just conscious of time. If we move on, go on.
So just on the bill's front, it is colossal. It is 326 pages, and anyone that watched season 1 knows that I'm not shy from legal and parliamentary geekery in any way. It is impossible to get through. I have a law degree. I have helped write legislation in government, and I was pulling my hair out trying to reconnect the dots of how everything works together. And I'm not boasting. I'm quite good at it. Like that was my job for a while. This is being pushed through at lightning speed with a lot of political power behind it. And
I can't believe it's already gone through the Commons.
But the Commons don't ever really read any legislation. They don't read anything normally.
The fact that it's so wide-ranging, if you consider how long they normally spend debating things that widen police powers, that widen these sorts of things, it is quite
if we're going to short this down to 2-second things, the thing you need to look at is the powers they're giving to get rid of around the Care Act 2014 to stop local authorities having a need to assess everyone. So there is a lot of stuff in there where we're just basically, many disabled people will not get proper health assessments and will not be guaranteed the personal care they need to survive. And Tammy Gray Thompson and 9 disability charities come out saying that this could lead to people dying at their homes because they will not have trained staff. And then there's also stuff around civil liberties and the powers they're giving to the police, which is very difficult to understand, and I've read that Schedule 4 times. And then there's finally the kind of surveillance powers about how they can use data and personal data. And there's finally an ultimate bit where this is the coronavirus bill, but they say it's all time limited. But how they haven't put in dedicated sunset clauses to certain powers. They've given declaration powers, and that's not the same. They could have said that this would all stop, the law would end, all the laws they put in place would end in September, say, 2020 or April 2021, and unless they had done something to keep it going, all this legislation would fall away. They haven't done that in many areas, and so this will stay on the statute book as long as they like. And once you give someone a power,
what Matt Hancock has said today is that his proposal is that it's reviewed every 6 months from the date that it's enforced. How pragmatic that actually is, be interesting, and what depth that review will go into is another question. But I'm just conscious that we will delve into that in another episode. But obviously, using the particular expertise that we have here, Dan and I could talk about that for ages. But if we go on to our sort of like medical deep dive aspect of things, so this is an area that for Lucia, I think you're going to be taking the lead on with some interjection from the Dans. So we know, obviously, I think most of us have a vague idea of what COVID is. You've very helpfully explained it at the beginning. We've been told repeatedly that people who are the most vulnerable are those who have underlying health conditions, the elderly, and conversely, that people who are very young, children in particular, seem to be able to cope with the virus or the disease much more easily. But what does that actually mean? So why does it affect, or does it affect children differently? Or is that just sort of an oversimplification of how it's been represented in the media?
No, it's not. I think Danny mentioned it earlier, is the key sort of groups of people that get the flu jab. So disease, illness, viruses, bacteria have been around and infecting us for the whole of eternity. Some diseases have, honestly, I'm not sure if we always know why, have sort of a target population where men get some certain diseases more than women, children get certain diseases more than adults. For example, we vaccinate kids for measles, mumps, and rubella because that's the disease, and for polio and diphtheria, because that was a disease that 100 years ago loads of kids used to die from, and child life expectancy was low. So we vaccinated children to protect them from that. You didn't vaccinate adults because once they made it to adulthood, there was this huge risk of being ill from it. Flu, just classic influenza, kills about 8,000 people in the UK every year, and most of those people are elderly. That kind of respiratory virus tends to affect older people who probably have less respiratory reserve, so their lungs are just not as strong as they were maybe 50 years ago to cope with an infection, and also perhaps weakened by underlying health conditions. So the same way we vaccinate these special groups for the flu, and if you'll get a text from your GP surgery if you're in one of these groups, be vaccinated because you're at higher risk. It's the same group of people that are suffering from coronavirus, which is a similar virus, just with much more or much more severe outcomes and really, really high quick sort of transmission. Going back to speaking about, I mentioned SARS, so that was 2003-04, and I think there was about 8,000 or less than 10,000 people died during that outbreak, which didn't really reach the UK, didn't reach as many countries, whereas we've got nearly 20,000 people have died already from coronavirus. So it's the impact that it's having is obviously very significant, and like other coronaviruses, it does tend to affect older people more than younger people. However, the more people are affected, the bigger of that proportion will be younger people. So the more people that get the virus, the more younger people you're going to see getting affected.
And do you think that has fed into the efforts to actually tackle the virus? Do you think the fact that we are constantly being told that those of us who are otherwise healthy, who are relatively young and so on, it's less likely to be a fatal outcome for us? Do you think 100%. That feeds into the mentality of the public?
Yeah, I think very understandably and reasonably so that you would think as a teenager or a 20-year-old that this virus is killing old people, affecting old people. I'm fine, so I can carry on with my normal business. And I guess it's not till more recently that the media has been pushing the advice is not about protecting yourself from the virus, it's about protecting other people from the virus.
Yeah.
Because if you have the virus as a young person, or actually any person, but there's a higher likelihood, particularly in children, that you might be asymptomatic or have really, really mild symptoms that don't really affect you. But if you go out, they estimate that potentially every one person with the virus can infect another 2.5 people. And over the course of 30 days, that kind of exponentially rises to 400 people-ish being affected. But if we reduce that by 50% at least by social distancing, then at the end of the same 30-day period, only about 15 people are affected. So it's these exponential curves in transmission rates are what we're trying to cut and flatten this curve instead of getting this huge, sharp, steep, upright rise in the number of cases. So yes, you're protecting other people.
Oh, yeah, Danielle's got her hands up, so we just shoot over to her.
Oh, yeah, I just wanted to add to that. I think that's absolutely right. But I think the other thing is that people have focused so much on the fact that it's older people who are affected by this virus that they've forgotten about the other vulnerable groups. So I think a lot of people are thinking, oh, well, I haven't seen my granny in however long. It's absolutely fine. I can go out. I'm not making anyone ill, without thinking that they might have a friend who has cancer or is pregnant or has asthma or who is 30. A lot of younger people fall into the vulnerable groups that are also affected by COVID-19. And I think those people are being ignored both by the media and by a lot of people when they're trying to work out what risks they're willing to take. So I think that's been unfortunate.
So we have a question from one of our live guests, which is saying, so with regards to isolating with family, if you live with someone who is in the high risk group, what are the rules for interaction within the household? So can anyone on the panel?
I think Danny, you probably do know this. I had it written down somewhere. I printed it off today.
I can answer that one.
Guidance.
I'm happy to answer that one. So the ideal thing, if you are, it's much easier now that people basically should be staying at home anyway. The idea is that if you are symptomatic and you are living with someone who is a vulnerable person, then you have to try as much as possible in the home to isolate yourself from them, which I know is much easier said than done. But that's the idea. Try very hard not to share rooms with them, or stay as far away. So socially distance yourself from them as much as possible, particularly if you're symptomatic. I think that that people are finding it particularly difficult. For instance, if they themselves are healthcare workers and they live with someone who is in a vulnerable group, this is particularly difficult guidance to follow. But that is the guidance, that try as much as possible to isolate yourself from them, particularly if you are still going out, and particularly if you're symptomatic.
Well, I've got a sort of a personal example, is that my sister-in-law is a teacher, and she teaches in an SEN school. So it's a school which has remained completely open because every single pupil that is in there has special educational needs. And she lives with my mother-in-law, who is in one of the vulnerable groups. So she's had to take the step of actually withdrawing from teaching at the school because the risk that she was presenting to her mother-in-law by going out, interacting with the pupils, and then coming back to the environment of being with her mother-in-law was too exposing. In that sort of respect, so that's a sort of conflicting area where on the one hand you have somebody who classifies as a key worker, but on the other hand, actually because of her particular home situation, her residential situation, it was far more important that she doesn't have that interaction with those pupils. So it goes to show how nuanced these approaches are. You have to be very aware of your own personal situation to ensure that you are prioritising the aspect of not interacting with people unless you absolutely have to. Felicia had her hands up.
I'm just kind of adding to that, and I'm not really adding any solutions. I'm probably adding problems. I'm not sure if you, Danny, have the same experience, but I, at the moment, all I do is speak to people on the phone, and 50% of those people are now concerned about coronavirus, whether they've got symptoms or not, or living with other people. And it is a very difficult one. I've dealt with mothers who have children with symptoms of suggestive of coronavirus. They can't isolate themselves really at all from a sick child. For a sick child, you're caring from them, you're caring for them, and then you're potentially with other members of the household. So they're having to find ways to isolate one parent with one sick child and keep everyone else away. I've had family members call and say they've moved out of the house and moved into someone else's house because of either symptoms or because of trying to social distance. So it is just really complicated, and in practicalities, you have the advice is there, but you have to interpret it the best you can to suit your home situation and your work situation. So, and then the pregnant women that are living in households with people who have symptoms as well. It's quite complicated. I've got patients who have not slept in the same bed with their partner for a couple of weeks because of all of this. So the impact on daily life is significant, and there's not a straightforward answer how to always deal with symptoms, social distancing, and isolation.
I think
it's particularly
a point
difficult
to make that I think she might want Danielle to respond to as well. Don't forget to unmute, Ros.
Sure. I was actually going to ask Lucia a question about technology. So if that is taking us away, Danielle, from what you wanted to talk to, if that was more in the public health space, then do, and I can always come back to my question about technology. Felicia, I was quite interested because I hope you don't mind, OJ, but about the use of technology, because you said that you've been doing phone calls, and I feel like that's kind of the service that's being offered to me as a patient as well. It's a phone call. Do you find that with all these accelerated processes and things that were available to us before, but now it just seems to be everywhere? So telephone conference appointments, video conferencing, everything now happening remotely or via technology. Have you noticed? Is it a good thing? Is it here to stay? I'm taking us slightly off, but I'm just interested for a frontline perspective.
No, yeah, that's really interesting, and something I've talked about a lot for different reasons, actually. One is that going back pre-COVID, a few weeks ago, pre-COVID, one of the big pushes in the primary care sort of workforce plan from NHS England was sort of pushing this digital first NHS, and that the NHS is quite behind on using technology. So the use of the NHS app, booking appointments, promoting self-care through technology, people accessing services directly through, using the internet like we do for everything else, whereas the NHS was still a bit slow, and you still have to call up your GP practice sometimes and sit in a queue or go there physically to get an appointment and have a face-to-face conversation that could have been done probably more efficiently using technology. So the irony is now, again, we're doing this at lightning speed. I've never seen CCG, so the bodies that sort of commission services, sort of implement brand new technology so quickly ever. Like, we're getting video consultation programs. I'm using my phone to speak to patients through like a link that I send to my phone, and then I can have a video consultation with them now. So it's really interesting. I think personally, if this goes on for long enough, primary care and how we interact, particularly in primary care with patients, will change, and there'll be a lot more use of remote consulting, a lot more video consulting, and I think that will stay. However, the problem we still face with the primary care situation, there are still patients you need to see that are not corona patients, and you still need to see patients if they have particular symptoms or signs. You can't just say, I'm not going to see you, let's have a phone conversation. You still need to see patients, and for some things you can't beat sometimes face-to-face interaction, which unfortunately we have to all put to one side for a few weeks or months. But there's a lot you can get from a patient or a conversation when you have it in person that we'll probably lose from doing so many telephone or video consultations. So there's like the downside.
Dan, I think you had a question, I believe. Your hand is raised.
Me, yeah. So I know I was going to echo that point around is innovation here to stay. I have spent the good part of my life trying to get people to do things a bit more effectively, and they've always said, no, but this is the way I've done my practice for 30 years, this is how it works, it's too difficult, we couldn't possibly do it safely. There's always been 1,000 roadblocks, and the slightly nicer thing about COVID is you're going to have to do this because otherwise there's no other way. And we've streamlined it, and people that were resistant to the idea of being able to follow up with a patient, that was just a review, being like, you had surgery 8 weeks ago, you haven't complained about any symptoms, but we're just going to come in and bring you in to see us for you to tell us that to our faces and us to double check your scans. That's all been on the phone now because there's no need to bring them in. And so things that are taking forever to try and resolve have been resolved in days. And I mean, like, yes, we've decided, it's done. It has been amazing. My favourite is when they've emailed me saying, we should have done this years ago. And I was like, I'm going to batter you, doctors. So I'm not. But like, the amount of times, some of them have now ironically started sending me emails about how well things are working. So we tried to get them to all of our consultants to use an app to dictate their letters, which automatically uploaded it to a cloud, which then downloaded it into the available secretaries for the right specialty to type up the letter, saving loads of time. They didn't have to move a tape. Would they do it? No. Do they all do it now? Do they love it? Yes, they do. It is literally turning everything around in about 45 minutes. It's ridiculous.
I can't support that. Just... It's amazing what really can get done when you're fighting for
HR.
When you have to.
HR is my favourite.
If
you've ever been in health and social care HR, you need something changed. Oh no, I think we need a working group. It takes months. I just wrote an MOU and said get that signed because that's what we're going to do, and it's working through. I think it would normally have taken 6 months. It took 3 days, which is nothing in the grand scheme of stuff.
Great. So if we just circle back, because I think Danielle was going to answer a question prior to us segueing into technology. Danny, did you still want to say what you're muted, by the way?
Yes, I am. There we go. Yeah. So my comment is sort of relating to what we were talking about before. So I'll be quick. But I was just going to say that. It's important to remember that key workers are also in vulnerable groups. You know, you have pregnant doctors, you have nurses who suffer from cancer, you have, and a lot of people, I mean, I suppose this is just, a shout out, but there are a lot of people who are taking really massive risks. All those people are coming back out of retirement are people who are in vulnerable groups, often who just by dint of their age are likely to get incredibly sick. And so we were just talking about how difficult it is to self-isolate. There are people who are leaving their families for months because they want to be on the front lines, but they also have a vulnerable person in their home. And so, when it comes to the workforce, I think it's really important to remember that these people are people and that they have all of those things going on as well.
Yeah, as a person who's classified as a key worker but in a completely different area, that's definitely something that we at the bar have been discussing and have been quite concerned about as well, because I think in terms of medicine and law, they're both vocations and they're both aspects, they're both jobs that you feel obligated to go to. I think very often as a doctor, as a nurse, as a lawyer, as a solicitor, you go to work even when you're not feeling well, and actually you're really having to change your mentality around that in this particular environment, because keeping calm and carrying on is often more detrimental than it is otherwise. But also, if you have a different type of vulnerability, such as being pregnant or having any other thing that could make you potentially at risk, you're constantly having to weigh up day by day whether you should go to work and assist others or whether you should prioritise your health and stay home. And it's a really tricky thing to do in reality, despite what the black and white wording of the policies may say. But if we now move over into social care and hear from Bami, who's we know somebody who has had almost a decade of experience in terms of managing care homes, we very often hear quite a lot when we talk about these healthcare policies concentrated on environments such as hospitals, GP surgeries and so on. But there's this whole other category of residential environment that these policies are really affecting, isn't there, in terms of residential care homes? And I'm really curious to hear from you, Bami, as to what adjustments you're having to make in that industry, in that environment, to make sure that you are complying with these areas of advice, with policies and so on, but still providing care to people who, frankly, are the most vulnerable in society.
Well, going back to where we started earlier with the rollout of the isolation program and how that was kind of slow, was kind of a slow burn. I think that was very key in allowing organizations like ours to catch up essentially with fast moving times, with fast changing policy. I think without that, would not have been able to, on a dime, switch in terms of how we manage our staff, how we manage our resources. That would not have been possible had a government immediately said that we're going straight into lockdown. We were given time to kind of approach things from a business continuity perspective, to really take into account how this affects our staff, how this affects our ability to get PPE, which, well, it's been quite hairy in recent days, I have to say, but
well, you spent all day trying to get PPE, haven't you? Let's be honest. You spent today looking for PPE. So for people who are unaware, do you want to just explain what PPE is?
PPE is personal protective equipment. So like things like gloves and the various kind of masks that you use in different scenarios when caring for people, aprons, hand sanitizer to a degree can be considered a form of PPE. And these things are obviously in massive demand right now and extremely hard to find. There is a national stockpile, an influenza stockpile that you can apply for access to, but the methods through which you do that aren't necessarily outside of the NHS work, although I don't have Trust ID or anything like that. It's very difficult to actually narrow down how to just get the ball rolling. I'm exploring about 3 or 4 avenues right now that I'm hoping to get somewhere with, but we'll see where that leads.
And so, just in terms of obviously with the idea of isolation or the idea of social distancing, people who are in care homes are obviously people who would very much look forward to receiving visitors, to having that sort of interaction to keep them connected to wider society. What sort of measures are being put in place for residents within care homes to ensure that their mental health and their connection to others in society is maintained?
Well, that's kind of the big irony about how this has panned out in the pandemic. Well, a global pandemic will remind us on a really large scale how much we need and rely on each other, how much the social interactions across all our lives in such myriad ways that are impossible to take into account. But at the same time, because of the nature of the pandemic, we are forced to separate, we are forced to disengage from each other. So as much as we're brought together, we're also kind of torn apart. It's weird. I mean, initially, because of like the extreme nature of the situation, the loneliness factor is taken for granted to a large degree, and it's not, at least at this early stage, it's not seen as a massive thing to take into account. As in, things are still changing on the ground. People are still acclimatizing. People are still managing staff and resources in that way, trying to ensure that morale stays up, ensure that circumstances that they might have with their children, their families, and their personal health are taken into account. So the loneliness factor is something to take into account later on, but that in itself does represent its own pandemic risk. Like it's a massive, there is a massive risk at play here in terms of loss of economic security for people. We have millions out of work, just thrown out of work over the course of a couple of days. We have bereavement to contend with, or we will have lots of bereavement to contend with in the coming months or weeks and months. And these things are all massively exacerbate the loneliness factor. And there has to be a really well-considered approach to managing that and dealing with that. And I haven't really seen that emerge as of yet. And it's a really difficult thing to do given the constraints of a pandemic and how we are forced to isolate. And how do you go about that? As in the internet does play a role as in communication and considered approaches that take into account safe ways of engaging with people without passing on the virus. But I think we've kind of demonstrated over the last 20 or 30 years that the internet, as great as it is for connecting people, hasn't really helped our loneliness problem in the way that we might have thought, as in amongst all age demographics, amongst all kinds of demographics, but loneliness is on the rise, even despite our increased connectedness. So it's difficult to envisage a way in which we can alleviate that. And I haven't really seen anything from the government.
Sorry, it feeds into what Felicia was saying before about the kind of wider ramifications of COVID and the fact that there are going to be mental health consequences that come as a result of this.
Yeah, I mean,
direct loneliness, the lack of interaction. If you already have any sort of mental health vulnerability, I can imagine that being forced to stay inside, losing any sense of that interaction, if you're not technically savvy, and so on, then it's only going to exacerbate those concerns. But it's interesting to hear you say, Bami, that frankly what seems to be happening at this moment in time is that there's a more immediate concern around just containing and flattening the curve, and that those things seem to be aspects that will need to be dealt with in future. Is that something that you agree with, Felicia?
Yeah, definitely. It's going to be a long-reaching issue. Even, again, looking pre-COVID, a lot of the work, and I'm sure Danny will know, around sort of new ways of working with, around engaging with care homes in a more connected way with primary care and social care, and getting these kind of personalised, unique ways of supporting isolated people, elderly people, disabled people. And we've got services like AGK who are heavily involved in providing those services, where they go to these lonely people's houses and get them out for a walk, or go and talk to them, or take them to a sort of a day centre or a dance class, and those kind of services, and connecting people with lots of community services, people that don't speak English, people with other sort of special or unique needs that just need help rather than medical help, just need some help, some advice, literally support. All of that's being pulled because you can't contact people, you can't be in contact with people. So there are already a group of people who needed that extra social support, which is now being taken away from them for potentially a long time, whilst we deal with the immediate stopping, the spread and flattening the curve. And then the ramifications of that are probably going to be multiplied, because it will be neglected. And without fault, we can't say that you can't let people go to people's houses, in and out of several people's houses every day to keep them company if you're spreading a virus to vulnerable groups. It's a catch-22, I guess.
So Bami, I have a question for you, and obviously I think it's important, particularly given what's been happening in Spain today, with reports of elderly homes being left abandoned, with even in some cases reports of dead elderly patients being left in beds. And I wanted to ask you about kind of like the legacy of the last 10 years of Tory government, and what that legacy has had on the social care situation now, and kind of where that leaves us going forward.
Was it asked me, because I missed quite a bit?
Yeah, so that's
No, it slowed down massively. I couldn't hear what was being said, unfortunately.
So essentially my question is, obviously, given what's happened in Spain, obviously with the reports of nursing homes being left, abandoned, with in some cases dead elderly patients being left in beds, and obviously knowing what's been going on in the UK over the last 10 years, with regard to kind of like the hollowing out of the budget for social care, where do you think that is going? Kind of like juxtaposing between Spain and the UK, where do you think that leaves us going forward?
There isn't really a great deal of clarity on exactly what broke down in Spain in order to allow that to happen. I mean, there is an investigation that's just started into that, but the idea of vulnerable elderly people being abandoned to succumb to the virus alone, only to be discovered by the army who are disinfecting towns, is the stuff of nightmares, and the exact kind of things we want to avoid in this country. I know it started there with like an issue of a lack of PPE for funeral care staff, who were reluctant to then go into homes to claim the bodies of the deceased, and staff at home, staff working in those homes for whatever reason, I'm not quite sure where the breakdown there was, but they essentially left those people, people in those homes that ran away. I'm not sure how. Well, I guess we'll find out in the coming weeks what actually led to that. We have been given robust guidelines in terms of ethical practice and and how to basically maintain the dignity, the dignity of people we care for under these circumstances, and the best practices in that regard. And I think material from the government has actually been really good and very comprehensive in that regard. But we're nowhere near on the same scale as Spain is in terms of progression of the outbreak. So it's hard to say, given how basically the social care infrastructure has been hollowed out over the last 10 years, whether or not we'll be able to basically maintain the standard that we would like to set for ourselves in terms of providing high standards of care, should things progress to a really, really stark level of turmoil. And only time will tell whether or not the mechanisms we have in place, whether it's stockpiles and delivery mechanisms, are up to the challenge.
And Dan, did you have something that you wanted to say there?
Yeah, so I've got one positive note and one negative note. I'm going to try and balance myself a bit more. So one of the weirdly positive things that came out of Brexit was our the amount of time and money that was devoted to contingency planning for no-deal Brexit, both in terms of the NHS and in social care, but also government, and the amount of teams that were just set up, which were instant response teams trained, and all of those things have just kicked in now. And one of the things that social care had was, if for some reason the economy collapsed and social care collapsed, how could you put in an infrastructure that meant care homes and people weren't missed? And so there was a lot of work done to map out what social care looks like in every area. And that was only kind of stood down in January. We're only in March. I know it feels like a long time, like 2020 has knackered us, but that wasn't there. So there's been a lot of infrastructure about how do we create a kind of a net under social care because of no-deal Brexit. So that all still exists and is being used now as this crisis unfolds. The bit for me, in which I think is really important about what the bill does, which we'll come on to another podcast, is it's the people that aren't in formal care homes. It's the people that may get a kind of budget that they get signed by their local authority every year to pay for their own ongoing care, and they're their own employers, so they employ their own staff to look after them, and that's not always centralized, so people don't know the care arrangements. So if those local care arrangements fail, they won't get picked up as quickly as if a care home loses 30 members of staff and therefore can't operate. The local authority will know that and should step in, and we should avoid Spain. But it's the people that have set up, in the sense, a limited company to look after their own care. Those people are probably the most at risk. And if you know anyone with long-term disabilities and care like that, reach out to them and make sure if they do have a problem that you know how to raise it for them. Like, I've got some friends I have one of my old employees in the Department of Health is disabled. She has to text me every 12 hours now, otherwise I get very worried about her and give her a call. But it's little things like that to say she can't go 12 hours without having to send me a message or me sending her one. So it's checking in, and that's not what way our society function. I think we come on into the next section where I wrote a very long rant about how I feel about what this proves to us from a wider policy perspective. So I'll stop there. But hopefully we should stop Spain. So
Bambi, what did you Bambi, you had your hand up there.
Yeah, I've seen lots of variants. We deal with four London boroughs. We deal with Havering, Barking, Dagenham, and Waltham Forest. And Havering, Barking, Dagenham, Waltham Forest, and Haringey. And I've seen lots of variants in terms of how they go about approaching issues like that. As in, Barking and Dagenham, for example, send out daily surveys, essentially, for updates regarding your staff situation and whether or not you've managed to establish links with other homes and other care situations. And they've been very good at linking people together in that regard, whereas others have been a bit more patchy in their approaches. So I guess there are mechanisms within local government to address issues like that, but I don't think they're being applied evenly. I don't think every council is up to the task in the same way.
It's not uniform in terms of just how prepared everybody is. And that actually leads me on to my next question for you, Bambi, which was to ask you, do you feel as though you are being provided with clear direction, with clear ideas of the welfare measures and so on that need to be implemented for the people that are under the care of your home?
Like I said, the material itself is very good, and peripheral organisations have also been very great. The information that they've been able to provide, the Care Provider Alliance and ACAS has had really good information that you can use, and there's support lines and hotlines that you can call, and those by and large are very helpful. But one thing about the material is that it is a lot of material. It is a lot of things to kind of take into account, a lot of things to implement. And that in itself is not an issue, but getting things down to staff in a way that bolsters their confidence and keeps them all up and helps them understand that we prioritize their health and we see them as a priority as well as the people we care for is more difficult. And I think it will become more difficult as time goes on, as more people become infected and people start weighing up their options and deciding whether or not they're willing to risk their health and their family's health and their well-being. We've heard about the issue in Spain, and as much as we want to imagine that couldn't happen in this country, I would not bet my house on that. So it's been by and large pretty good. I mean, I feel like we were given plenty of time for business continuity planning, so we're able to use that as a framework in order to guide our process, and we're given loads of material on how to go about that, specifically with regard to the virus. So I feel like we've been well prepped, but only time will tell whether or not we're equal to challenges that may arise that we're not quite abreast of yet.
So the last part of the today's episode, because I'm just bearing in mind that we started at 8 and it's now 20 minutes past 9, and we were supposed to be an hour-long episode. So the last parts that we had were to look into what we think the long-term consequences would be, and I think actually over the course of our discussions we've covered a lot of that. We've spoken about the changes that it may have in terms of the way that things are done on higher levels, the use of technology, the emphasis that we now have and a recognition that we now have on how much we rely on interactions with one another. But Roz, I know that you had some thoughts on this area in particular, and that you, as well, Danielle, wanted to talk about the fact that the impact goes far beyond just COVID itself. So if we start with Roz, go to Danielle, and then we'll end with Dan with the rant that I know he's been gearing up to over the course of this entire episode. So if we start with Roz.
Well, I think the interesting thing here around the long-term consequences is how long are we going to be in this kind of crisis mode, and that really goes to something we talked about earlier about the exit strategy. So, is it going to be a vaccine? Well, we're hearing at the earliest 12 months, 18 months away, if it's even possible. So you've got that as a potential option. What's the word I'm looking for? Herd immunity. That looks, I think we thought it could be, I think early modelling thought it could happen, but of course the virus accelerated at such a rate that it was just creating too much pressure on our capacity. So, and again, there's no evidence that we're going to get there anytime soon. So you've got that. And then what are your other options? Well, it is containment. It's the society societal measures that we bring in to try and control behaviour. So really, the only thing at the moment that we do have is that third one around basically restriction of movement of people, which will, halt the movement of the virus. So until either two of the others, either herd immunity or a vaccine emerge, we could, as I said, I think earlier, see us oscillating between different strategies of lockdown, or some kind of lockdown, maybe regional, and kind of more relaxed movement of people. But I think it's going to be a long time before we have national borders open, free-flowing, airports up and running again. It's going to take us a while. So it's going to be interesting to know what the long-term strategy is, because or consequences, because I think we could be in this phase for quite a bit longer, which isn't a very jolly thing to say, so I'm sorry about that, everyone.
All right. So on that happy note, if we move over to Danielle, Bami, I see your hand up. We'll come to you afterwards.
If it helps at all, what I'm about to say isn't any more jolly.
Oh God.
Yeah, sorry. But basically, when we look at in public health, when we look at huge things like pandemics, we have to look at what we call externalities. So other things that happen that have a health impact that aren't just to do with the pandemic or whatever itself. And so, I mean, you can kind of divide it up. The first thing that we saw with things like Ebola were that mortality from other things went up quite significantly. So things like malaria, maternal mortality, stuff like that, because people can't get healthcare, infrastructure breaks down, all of that sort of stuff. So we really need to be looking out for that sort of thing when we think about what's going to happen over the next year, 2 years, 3 years. Apart from that, there are going to be huge health impacts of the fact that we've had to quarantine. So loads of things, stuff like domestic violence may well go up because people are suddenly trapped with their abusers. Child abuse might go up. Smoking may go up. Alcohol use may go up. Falls in older people because they don't have the support networks that they previously had. There are lots of health outcomes that may get significantly worse because of the breakdown of infrastructure that we have because of COVID. And I think that that's something that a lot of organizations are planning for, but it's difficult to know exactly what's going to happen. And then on top of that, this virus in particular has the potential to exacerbate health inequalities. So this is something I bang on about a lot. I talked about it last time I was on. There's already a huge life expectancy gap between the rich and poor. And when you add in a virus that you're more likely to get if you have heart disease, lung disease, if you're working in a setting where you have to see a lot of people. So for instance, waiters, taxi drivers, people who live in the gig economy, if you're more likely to get it because you can't take time off work and you're more likely to go into work symptomatic. If you're living in substandard housing, which means that you can't isolate from other people, all of that could potentially really widen the health inequalities that we already have in this country. And so I think when we think about an exit strategy, when we think about what's going to happen over the next few years, we really have to think that there's a lot of, it's not just about the people who had COVID and the morbidity and mortality from that. It's also about all of the things that happen because of everything we've had to do to try and stem the disease itself.
And then Bami, I think you had your hand up.
Oh, sorry. One thing I forgot to mention that I think will play a large role in determining how much of a horror show this virus ends up looking like for us in this country, in both the medium and the long term, is hospital discharge and the extent to which the NHS has already been backed up by the dearth in social cuts in local government social care provisions, and how people are stuck in beds for extended periods of time, and whether or not people being discharged from hospitals having had the virus are able to reintegrate back into either care provisions or their own homes. I think if we see a situation where people just end up stuck in hospitals, we could have a mild disaster on our hands in terms of how the virus ends up playing out.
Yeah, that's a good point. All right, so Dan, what did you want to say? I know that
it
when
was
we
described as a
topics,
rant.
you had very strong views that you wanted to put across in terms of the wider aspects of things.
So I'm going to change it from what was described as a rant, is it's how I wrote it, to try and end positively. I'm going to give it a go, guys. It's been a tough couple of weeks. But from a wider policy perspective, and that's how I kind of see the world, and the first season geekery has probably not been lost of anyone that's rejoining us, Danielle, Abby. But what I would say is what we have completely failed to do as a society is fix the roof when the sun was shining. We like to pretend that we are always in crisis, that there's always some big problem, and that we must focus on a new shiny thing that will make us all fix it. And healthcare and social care is particularly fond of transformation projects and new boards and new organisations. And fundamentally, what COVID has shown us as a sector is it is not about a new shiny hospital subspecialty in this. It is about knowing who in your local hospital that works 20 minutes down the road you can talk to about doing a joint pathway and sharing stuff. It's about managing relationships within the sector, and it's about getting the simple things right. It's about reducing waste and amount of work that we do. It's about making us work more intelligently and smarter and following the evidence. But what it has shown us on a wider policy perspective is that we let a lot of things slide as a society. There has been so many reviews on how the gig economy is failing many of its workers, and that came out in what, I think 2017. Have we done anything?
Yeah.
No. So no one's done anything, but now we all know that's a big problem because they're all still going to work, but we can't stop them because we never tried to fix it when a good time was coming. We all talk about the problems with housing and welfare and the problems with the system, and the system hasn't been working in the good times. So now it has to deal with an extraordinary emergency. Of course, it won't cope. So next time someone asks you for their vote, or next time they ask you what you think about something, and you go, well, it doesn't affect me now because I'm employed, I'm healthy, I'm fine. Those things that you don't use daily become essential to you in a pandemic and an emergency. And we seem to forget that all the time. And I hope, and I really do hope this is the response from COVID, is that we start really caring about the detail of how our society works and don't leave it to somebody else to fix. It's not just up to sad people like me to read 326 pages of a bill and say, that doesn't make sense. It's not for very specialist groups. It's on all of us to take an active interest and say, will this work in a COVID-20 or a COVID 2025? And if it's not, if our society's not ready and we're not got a plan to be ready for the next pandemic, it means we haven't fixed the infrastructure we need to make a society work. And that's I think the big policy challenge post COVID, is to say, yes, there's been problems, but how do we make sure the system is better fundamentally as a starting point than it was before we started this pandemic?
Yay, Dan for Prime Minister.
No, because we didn't say any of the rude comments I wrote about people in the notes, did we?
Shh. Okay, and so I think it's a good point for us to bring the episode to an end. But I thought that what we could try to do is try and end on a slightly positive note. So maybe we could go around. Oh, go on, Felicia. Say something positive.
I want to say, despite all that's been said, and I have a lot of concerns and negative thoughts about what's going on, but again, when wider policy an issue, but when we come down to like on the ground, there are a lot of people out there who are actually risking their own health to like help people through this crisis. I've had, I've still seen patients with masks on and stuff, seeing with potential symptoms. There are a lot of people who are treating, very unwell coronavirus positive patients in hospital. Even patients even people, as we mentioned, staff who probably shouldn't be working in hospital right now because they are vulnerable themselves. They've got their own health conditions. They may be pregnant. They may be looking after people at home. So not that that's a good thing, but the lengths that some people are going to continue to help care for people through this are quite sort of astonishing, and it's quite amazing what people will continue to do when you've got a vocation. You feel like, this is my job, I'm obliged to do this. And unfortunately, some people are willing to take some risks for other people, or fortunately, people are willing to take some risks for other people.
Yeah, it has been definitely sort of heartening, and also even just hearing stories about the letters that people have been posting through their neighbours' front doors, letting them know that they're there to assist them, the conversations that people are starting to have with the people who live around them and getting in touch with them. So there are positive and happy stories, and hopefully happy legacies that will come out of what is overall a really serious and quite disheartening situation. So the thing that I was going to suggest that we do before we sign off, and hopefully we can do it within less than a minute, is for each of us just to name one thing that we have taken up, watched, whatever, time at home and less time socializing. So I've downloaded TikTok And I think I finally persuaded Jack to do a TikTok video with me. So I will be doing that tonight.
I can't wait, by the way. I can't wait.
Thanks, Alicia. Dan?
What's TikTok?
Danny!
I'm kidding. I'm kidding.
I don't have it. So when I cleared out an old relative's house like years ago, I found a book of old stamps from around the world, and some of them are like from like the Soviet Union and lots of random places, and they're really old. And I always kept going, I'm going to do like a project where I'll like take pictures of them all, and I write a short description of what they look like, and I Google image search them all, and I just hope that they're worth some money. And normally you always have something better to do than go through 400 stamps to find out if they're worth any money. But don't anymore. Yay! I'm praying for a house deposit. Just on a side note, stamps are worth a small fortune apparently in some places. Thank you guys.
I just love how much of a geek you are, Dan.
Yes.
Roz, what have you been up to?
I've actually tried to do that, the DIY that you just don't get ever around to doing. It turns out there's a reason why I employ people to do it for me, because I'm really bad at it. And so today I tried to fix a shelf by sawing off an end. I sawed off the wrong end, and now it's not a square, so it's miles away from fixing it. It's bad. So yeah, stick to the day job.
Brilliant. Danielle, what have you been up to?
So I'm not alone in this. Animal Crossing came out on the Nintendo Switch a couple of days ago, and that has been my life. Me and my fiance have been playing it pretty much all the time when I'm not working, and it is amazing. If you're a person who plays games, if you haven't got Animal Crossing on the Switch yet, that is your quarantine game, I promise.
Alicia, what about you?
I'm still going to work as normal.
Yeah, I was about to. As I went to her, I was like, "Oh, Felicia doesn't work until 9 p.m. yesterday." So
I'm still at work as well.
Yeah, I mean, I am too.
I have been obviously being the other part of my life, being a massive health and fitness freak. I can't go to the gym, so I have been able to like be more creative with my home workouts and put my weights and my bands. So and I've been started doing some more yoga. I just got into yoga, and then the gym closed, and now I'm doing some home yoga. My little app, put it on the screen. So I have changed the way I live, but I still have to go to work.
I was quite worried now that I have to exercise daily outside. This new guidance is really making me a lot healthier.
You know what? In public
people weren't doing that before.
Yeah. We've been trying to get people to exercise for years. Who knew what we needed to do was turn it into a treat?
Yeah, exactly.
Very excited.
Sammy, what about you?
I just wanted to ask, going back to Roz's shelf sawing, are we expecting, just want to ask our doctor, are we expecting a bunch of people coming into A&E because they were bored at home doing DIY?
Yes.
Is that really going to be a thing?
Yeah, it was bad. Honestly, at one point, the saw was enormous. It was longer than my leg, and I missed swipes, and I was like, oh my God, I could have taken my leg off. And then I was like, that's really irresponsible, because the A&E department can't take another person. So...
No, it actually, A&E's quite quiet.
Guys, this needed to be like 2 minutes long.
I could do a live shot of A&E if you wanted.
Right, Aya, what have you been up to? Aya, what have you been up to?
So I'm going to basically say the complete opposite of you, and I've successfully spent my time avoiding TikTok and avoiding any suggestions from my wife to engage in it. I've been successful thus far. Just wish me luck for the rest of this isolation distancing period.
Can I just let you all know that what Aya has been doing is playing keepy uppy with toilet paper, and
which I still use,
and doing increasingly long press up challenges on Instagram. So this whole I don't do TikTok is no better than the rest of us. Thank you very, very much. All right, guys, we're going to wrap up the.
Wait, hold on, you didn't say yours. Oh, you did say yours.
I did. I started. I said it.
Yeah, you did say yours.
So we're going to wrap up the episode there. Thank you ever so much to all of our panelists for joining in, especially those of them who are still at work. I think that is Dan, Danny, Felucia. I think Bammy is probably still on call, and to be honest, Roz has a newborn baby, so she's
24/7 on call. Yeah,
yeah, exactly.
Just a reminder, guys.
Congratulations! Congratulations!
I don't know if you wanted me to share that, so yeah, sorry.
Yeah, just a reminder, guys, that the episodes will be available on our usual podcast channels. We will obviously have the live version, which will go on YouTube, but the this version will go on our podcast channels. The sound version will go on our podcast channels. And also remember to subscribe to all our various channels.
So we're on Instagram, we're on Twitter, we will be on YouTube, we're on Spotify. So make sure that you follow us on whichever channel it is that you listen to us, that you follow us on social media to make sure that you keep up to date with what we are up to. And stay tuned for our next episode, which will be an education-focused episode and should be coming out this weekend. Awesome. Thank you guys very, very much.
Thanks, guys. Take care. Bye-bye.
Bye.
Bye.